Okay, hello, welcome to my channel. So today we're going to continue with the integumentary system in our anatomy and physiology lectures, but specifically today we're going to talk about maintaining homeostasis. We will talk about skin wound healing. Okay, so we are going to talk about skin wound. Okay, so let's start with some definitions. Okay, so a wound is a disruption in the integrity of the skin, mucous surfaces, or tissue. Organ tissues. Okay, that is one definition of wound. Okay, then what is wound healing? Okay, then wound healing is a complex biological process which results in the restoration of tissue integrity. Okay, so here we are restoring the tissue integrity. Okay, or restoring the skin integrity, mucous surfaces integrity. Okay, that is wound healing. Let's continue. There are actually 4 phases of wound healing. So phase 1 is hemostasis, so which happens the 1 to 3. Then its framework, its importance is to stop bleeding. In our phase 2, which is the 3 to 20, where there's the inflammatory phase, whereas there's no new framework for blood vessels growth. Then you have phase 3 for proliferation or granulation, which can take week 1 to 6. Okay, then we have so under proliferation, this is where you pause the wound closure. Okay, then phase 4 is for fine or proper tissue. Okay, so which occurs week 6 to 2 years. So this is under remodeling or maturation. Okay, so in short, remodeling or maturation can take up to 6 to 12 6 weeks to 2 years. Okay, so then now let's look at the phases one by one in details. So we find that in hemostasis, at the time of surgical incision, a vascular injury occurs on a macro or microvasculature scale. Then the immediate response of the body is to prevent exsanguination and promote hemostasis. Okay, then damaged arterial vessels rapidly reconstrict through the contraction of the smooth muscles in the circular layer of the vessel wall, which is mediated by increasing cytoplasmic calcium levels. Then within a few minutes, the reduced blood flow mediated by the arterial constriction leads to tissue hypoxia and acidosis. Okay, this promotes the production of nitric acid, adenosine, and other vasoactive metabolites, which cause a reflex vasodilatation and relaxation of the arterial vessels. Okay, then simultaneously, histamine release from the mast cells also acts to increase vasodilatation and increase vascular permeability, facilitating the entry of inflammatory cells into the extracellular space around the wound. Okay, then further blood loss at this stage is also prevented through the formation of a clot, which is achieved through the key mechanisms. Okay, number 1 mechanism is the intrinsic pathway. Okay, which intrinsic pathway of the clotting cascade, where we have contact activation pathway, endothelial damage as a result of tissue injury, which exposes the subendothelial tissues to blood, which results in the activation of factor 12, which is the Agman factor. Okay, this initiates the proteolytic cleavage cascade, which results in the activation of factor X, which converts prothrombin to thrombin, resulting in the conversion of fibrinogen to fibrin and the formation of a fibrin plug. This is the intrinsic pathway. Okay, the next is the extrinsic pathway of the clotting cascade, which is now the tissue factor pathway. Okay, where we have the endothelium damage, which results in exposure of tissue factor, which of course present in most cells, to circulating blood. Okay, then this results in activation of factor 7 and the rest of the extrinsic pathway of the clotting cascade, which will eventually result in thrombin activation. Okay, so this is what we are talking about, the extrinsic pathway. Okay, and of course the extrinsic pathway and the intrinsic pathway. Okay, so then the other mechanism is the platelet activation. Okay, which of course following activation by thrombin, thromboxane, or adenosine diphosphate, platelets also undergo a change in morphology and secrete the contents of their alpha and dense granules. Then you find that activated platelets adhere and clamp at sites of exposed collagen to form a platelet plug and temporarily arresting bleeding. Okay, then this plug is strengthened by fibrin and von Willebrand factor, as well as the actin and myosin filaments within the. That is one of the other mechanisms. So this is the platelet uh, factor. So there is primary platelet adhesion. Okay, the platelet goes to the wound site to make a platelet plug. So the platelet aggregation is going to occur here. Okay. Then there are some growth factors that are involved in wound healing. Okay, so you have platelet-derived growth factor, ependymal growth factor, fibroblast growth factors, transforming growth factor, and also vesicular endothelial growth factors. So these are some of the growth factors that are involved in wound healing. But for now, you can pause and even go through the locations and their target of virological effects. Okay, so just in case maybe you might be asked. Okay, but otherwise, as we are going to move forward. Okay, so it's important if you actually notice. Okay, we have growth factors such as platelet derived growth factor, ependymal growth factor, fibroblast growth factor, transforming growth factor B, beta, vesicular endothelial uh, growth factor, which is usually abbreviated as VEGF. Okay, and its location is in the pituitary cells. Okay, the target tissue biological effects are mitogenic for endothelial cells but not keratinocytes, and of course smooth muscles or fibroblasts. Okay, so I think let's move now. Okay, so this is what you are talking about, major components of hemostasis. So okay, when someone is having vesicular damage, of course it's going to be vasoconstriction, platelet aggregation. Okay, and there is a back and forth mechanism for coagulation cascade. Okay, so this is after the coagulation cascade, then it may lead to, so platelet activation may lead to platelet plug, then coagulation cascade may lead to conversion of fibrinogen to fibrin, which leads to a blood clot. Then finally plasmin and fibrinolysis and clot degradation will occur at a later stage. Okay, so the second stage is inflammatory phase, where there's a key aim of this stage is to prevent infection. The neutrophils are the first responders, and they are highly motile cells which infiltrate the wound within an hour of the insult and migrate in sustained levels for the first 48 hours. And this is mediated through the various chemical signaling mechanisms, including the complement cascade, interleukin activation, and transforming growth factors, TGFB, okay, and TGFB signaling, which leads to neutrophils passing down a chemical gradient towards the wound. The process termed as chemotaxis. Okay, then there are three main mechanisms for destroying debris and bacteria. Number one mechanism is phagocytosis. Uh, the other one is degranulate and release a variety of toxic substances such as lactoferrin, protease, neutrophil elastase, cathepsin, which will of course destroy bacteria as well as dead host tissue. Then the other the main mechanism, the last one is the oxygen-free radicals, which are produced as a byproduct of the neutrophil activity, which are known to have bactericidal properties, but can also combine with chlorine to sterilize the wound. Okay, so these are the three main mechanisms. So don't worry about the four. This is just a continuation of the statement here. So phagocytosis to produce toxic substances, oxygen-free radicals. So let's continue. So then, of course, the other apart from neutrophils, Then under inflammation, the other cells are the macrophages, which are much larger phagocytic cells, which reach peak concentration in a wound at 48 to 72 hours after injury, and they are attracted to the wound by the chemical messengers released from platelets and damaged cells, and they are able to survive in the more acidic wounds environment present at this stage. And they harbor a large reservoir of growth factors such as the TGF beta and ependymal growth factor, okay, which is EGF, which are important in integrating the inflammatory response, stimulating angiogenesis, and enhancing the formation of granulation tissue. Then the other cell in inflammation is the lymphocytes, which appear in the wound after 72 hours and are thought to be important in regulating wound bleeding through the production of an extracellular matrix, scaffold, and collagen remodeling. Okay, so this is the inflammatory phase we are talking about. Okay, which is said inflammation. We are take care of the debris and of course the bacteria. Okay, that's what we are saying. Okay, if there's tissue damage, insult, or injury, okay, is leads to a response, which is chemical mediators such as cytokines are going to be released. Then there's going to be a vascular response, a cellular response, but together it will still lead to chemical mediators and cytokines being released. Then there's going to be vasodilatation and vasopermeability, and of course the end result is that here there's going to be tissue edema, and here is going to be debris clearance, okay, as well as clearing of bacteria. Then the third stage is proliferation. Okay, so this is a complex process which incorporates angiogenesis, the formation of granules, granulation tissue, collagen deposition, epithelialization, and wound retraction, which occurs simultaneously. Then angiogenesis. So under proliferation, number one process we are now with angiogenesis. Okay, then under angiogenesis, we all know that it is triggered from the moment the homeostatic plug has formed as the platelet released the TGF beta and platelet derived growth factors and fibroblast growth factors as well. Then in response to hypoxia, vesicular endothelial growth factors is released, which in combination with the other cytokines induce endothelial cells to trigger neovascularization and the repair of damaged blood vessels. Initially, the center of the wound is relatively avascular, as it relies solely on diffusion from the undamaged capillaries at the wound edge. Okay, then as the process of angiogenesis proceeds, a rich vascular network of capillaries is formed throughout the wound from offshoots of healthy vessels. Initially, the capillaries are fragile and permeable, which contributes further to tissue edema and the appearance of healing granulation tissue. This is under angiogenesis. Okay, apart from angiogenesis, we have fibroblast migration. Okay, so fibroblasts are stimulated to proliferate by growth factors released from the homeostatic clot and then migrate to the wound. Because dominantly the factor is TGF beta and PDGF. Okay, then by the third day, the wound becomes rich in fibroblasts, which lay down extracellular matrix proteins such as iroran and fibronectins and proteoglycans, and subsequently produce collagen and fibronectin. Then the resulting pink vascular fibrous tissue, which replaces the clot at the site of the wound, is termed as granulation tissue. Then this is composed of a different range of collagens, a higher proportion of type 3 collagen than to that seen in an wounded tissue. Once sufficient matrix has been laid down, fibroblast change to a fibroblast phenotype and develop pseudopodia. This enables them to connect the surrounding proteins, fibronectin, collagen, and assist in wound contraction. Then collagens synthesized by fibroblasts are the key component in providing strength to. Okay, then C, which is epithelialization. So epithelial cells migrate from the edges of the wound very soon after the initial insult until a complete sheet of cells covers the wound and attaches to the matrix below. Okay, then an embryonic process termed epithelial mesenchymal transition, which is EMT, allows epithelial cells to gain motility and travel across the wound surface. Then changes in cytokine concentration result in the epithelial cells switching from a motor phenotype to a proliferative one in order to repopulate epithelial cells cell levels and complete wound repair. Okay, then wound retraction, then wounds begin to contract and about 7 days after injury, it's mediated mainly by the myofibroblasts. Then interactions between actin and myosin pull the cell bodies closer together, decreasing the area of tissue needing to heal. Okay, then contractions can of course occur at a rate of 0.7 millimeters per day, leading to a shortened scars. Then this is influenced by numerous factors, including wound shape, with linear wounds contracting faster and circular wounds the slowest. Okay. So this is the proliferation phase. So we have cytokine-based drivers from the inflammatory events, which can lead to fibroblasts and endothelial cells proliferating and increasing activity levels. Then fibroblasts, of course, are going to cause collagen-based scar tissue. Then endothelial cells angiogenesis, okay, on your vascularization, enhance local circulatory activities as well. Okay, then together these mechanisms, the cytokines based events also lead to myofibroblast formation, which leads to wound contraction and enhanced repair tissue state. Then the last stage, which is remodeling. So final stage of wound healing can take up to 2 years. Okay, and the results in the development of the normal epithelium and the maturation of the scar tissue. So that is why most of the time we find that we usually advise women who have undergone cesarean section, for them to conceive again they must take a 2 completed years. So meaning if someone was to get pregnant in 2020, or if someone was to give birth, okay, if someone was to undergo a cesarean section in 2020, okay, then they should go 2 years without getting pregnant. So meaning 2020, 2021, 2022 without getting pregnant. And if they want to get pregnant, then of course they should do it in 2023. That is 2 completed years, because of the final stage which actually may take up to 2 years. So this is some applied anatomy here. Okay, then of course if someone was to get pregnant within 1 year, we usually recommend a Caesar. We don't necessarily allow them to deliver via vaginal birth because of the higher chances of the uterus rupturing. Okay, since wound healing has not necessarily taken its maximum time. Okay, so in this phase involves a balancing between synthesis and degradation. Then as the collagen and proteins deposited in the wound become increasingly well organized, they will regain a structure which is similar to that seen in unwounded tissue. So there is replacement of type 1 collagen with type 3 collagen. Okay, so this is remodeling we're talking about, where there is orientation of collagen fibers. Okay, and of course orientation of collagen fibers may lead to a structure of the final tissue which resembles the parent tissue as close as possible. and provides enhanced quality and functional capacity. Apart from orientation of collagen fibers, there is also the absorption of early predominant type 3 collagen. So of course type 1 is converted to type 3, which leads to replacement with the predominant type collagen. Okay, and of course this again we just read to the same. Then factors affecting wound healing. So local factors, we can have moisture, and we can have mechanical factors, we can have edema, ischemia, necrosis, foreign body, low oxygen tension, and as well as perfusion. Okay, these are local factors. Then systemic factors affecting wound healing, we have inflammation, diabetes, nutrients, metabolic diseases, immunosuppression, connective tissue disorders, smoking, age, and alcohol. This can affect wound healing. Okay, then wound healing closure. Then how do we the processes of closing up a wound? Okay, we have primary intention, where of course if you have a clean incision, then and you have aid suturing, you can actually just have an airline scar. Okay, then if you have a gaping wound with blood clot, of course this one you just heal by granulation tissue, which is going to fill in the wound. There's going to be a large scar, and there is actually no, you haven't sutured anything in this scar, so this will heal by secondary intention. Okay, then you have tertiary intention, which of course is delayed wound healing. Okay, or delayed wound closure. Okay, then after you delay, then you can to suture it after. Okay, so contaminated wound, then if it was contaminated, you are doing wound cleaning, then it starts forming granulation tissue. Okay, then at the end, then you actually close it with the wide scar. That is tertiary closure. Then these are the stages of the four phases of wound cleaning we are going through. So we can actually just pause and go through. That's it. Do your own recap as we are moving. Okay. This is also another one. So I think let's move. Let's move. Okay, so we can pause in short and go through. But this is the things we were going through. Okay, then complications of wound healing can have a deficient scar formation, excessive scar formation of repair components, and also exaggerated contraction. Okay, so deficient scar formation can lead to two types of complications. Sometimes it can lead to wound dehiscency, where there's rupture of wound, and it's most common after abdominal surgery. And of course, when you're coughing or vomiting, especially coughing, you need to increase intra-abdominal pressure, which might rupture the wound. Okay, then the other complication is ulceration, where if there's a, especially if there's a defect in the continue, which leads into especially if there's a defect in the continuity. Okay, so this is wound dehiscency. Okay, this is wound dehiscency. Okay, this is wound dehiscency. Okay, then excessive formation of repair components. Of course, this can lead to keloid or hypertrophic scars where there is excess collagen. You can also have exuberant granulation or proud flesh, and of course there is going to be excessive granulation tissue that protrudes above the level of the surrounding skin and impairs the growth of epithelium. Okay, then keloid or hypertrophic scars. Okay, these are raised scars due to accumulation of excess amounts of collagen, specifically type 1 to type 3 to type 1. And then the hypertrophic scars do not actually grow beyond the boundaries of the original wound. And other teachers will even tell you to say actually they even actually stop growing. They don't go when growing, they don't go beyond the 6 months. But keloids are more serious because they grow beyond the boundaries of the original scar, and they can even grow more than 1 year. They are still just growing. Okay, so that's about keloids or hypertrophic. Okay, so these are keloids. Okay, then this is an exuberant granulation or proud flesh. So this is excessive tissue granulation, it protrudes above the surrounding skin. Okay, and this will just prevent re-epithelialization. Okay, so when you have granulation tissue, that excessive granulation tissue. Okay, then the other one is exaggerated contraction. So this is a deformation of surrounding tissue or wound which can compromise the movement of joints. So most common of the palms, soles, anterior thoracic, and of course following severe bends. So that's why in bends it's very common. We allow that's why it's very common to allow physio in bends. Don't want them to develop contractures. Okay, then that's the end of the tutorial. If you haven't subscribed, please subscribe and the bell notification, and see you in the next tutorial videos.